Great, because I hate being tethered to things like microphones. Today is an overview lecture. You know, usually when I do something like this, I'm given a specific diagnosis, a specific topic, and I really kind of bore into that. So as an overview lecture, I'm going to hit on a number of things, and I'm not going to go into the kind of depth that I would on a specific lecture to any one of these issues. If I've timed it properly, I'm going to finish the formal part of the talk relatively quickly, and there will be lots of time for interaction, questions, and answer. Also, I'll probably hang out for a while afterwards, because sometimes people have questions that they would prefer to ask one-on-one. So let's see if I can make the technology work here. Okay, so what are the 5 issues that we're talking about? The first is a large category of diagnoses called the anxiety disorders, and we'll list each of them shortly. The second is major depressive disorder, which is the technical term for what folks call depression. It used to be called clinical depression. The third is bipolar disorder, which I really had to rein myself in, not to go overboard on that topic, since it's a consuming interest of mine. The fourth were the eating disorders, and we'll go through each of these briefly. And then finally, suicide. A lot is said about teen suicide, and I'd like to share the statistics with you, and also an idea of what works in terms of preventing teen suicides. Okay, the anxiety disorders. Most of the stats we have on these are on adults, but at least 25% of adults have anxiety disorders if you throw in things like social anxiety. There's a 17% lifetime frequency of social anxiety disorder. The teen statistics are hard to come by, but as somebody who's treated thousands of people with anxiety disorders, I would say that just about everybody I've seen had the onset, certainly by the graduation from high school. So typically, adolescence is when we start to see these things. The different anxiety disorders include generalized anxiety disorder, which is, I remember laughing about this diagnosis the first time I read about it, because I thought, who doesn't it apply to? But it's excessive worry or concern about 2 or more areas of life, but it's the second part that's important, that is severe enough to cause life impairment. And we all get anxious about things, but the question is it causing us trouble in our day-to-day life? Social anxiety disorder involves having great anxiety when you have to meet new people. Often, if you have to go somewhere where there are a lot of new people you have to mingle with, this sort of thing. And it can have huge life impact, and often declares itself in the middle school, high school years, when kids are starting to socialize, starting to have a romantic interest, this sort of thing. And it can have really substantial consequences, right down to academic failure, because they're often afraid to ask a question in class. Panic disorder involves these sudden attacks, often unprovoked, of this sense of impending doom. The heart tends to go fast. People sometimes worry that their heart is going to explode and they're going to have a heart attack. They often sweat profusely. They may get a tremor. They may feel nauseous. And there's just this incredibly uncomfortable feeling in the mind that varies from a sense of impending doom to just a sense that something terrible is going to happen, or a sense that one just has to get away from whatever is going on. All right, obsessive compulsive disorder, or OCD, involves either obsessions or compulsions or both. What's an obsession? It's important, I want to be pretty precise about this. An obsession is an intrusive, meaning you're not trying to have the thought, you're not thinking about something you like. It's an intrusive, unwanted thought that you resist and try to put out of your mind but are really unable to do so. Sometimes these are thoughts about disturbing things. Sometimes there are disturbing images, and children will often hear about disturbing visual images that get stuck in their head and cause them a lot of trouble. Compulsions are, what else? Compulsions, wait a minute. You know, my wife reworked these slides, I'm going to have to blame her. Compulsions are behaviors that you have to engage in that are time-consuming, don't really serve much of a useful purpose, and cause life impairment. You know, examples of compulsions can be having to count things, having to check that the doors are locked, 6 times. Compulsive washing, I've treated people who would take 4 hours to make it out of the bathroom because every time they did the ritual, they felt they touched something and then they got to start the whole washing ritual over and over again. The most interesting one I ever saw was a mental compulsion in this super bright 7th grade girl. And they brought her in, this was when I was on the East Coast, they thought maybe she had ADD or something because her grades went from straight A's to F's. Well, you don't get ADD that way. And so I talked to her, and she informed me that she had the compulsion to think in iambic pentameter. I'm not even sure I remember what iambic pentameter is from my poetry days, but imagine having to think that way. Well, she couldn't focus on, anything else at all. Untreated, these anxiety disorders in anyone, teens included, can be pretty devastating. Grades can fall substantially. One can find oneself unable to make friends or socialize or engage in all of those activities that teens engage in that prepare them for adult life. And extreme anxiety is also a risk factor for completed suicide. Treatment of anxiety disorders. Well, first of all, they are highly, highly treatable. And that's an important kind of walk-away message for you or any teens you know that are having trouble with anxiety. Typically, we combine a style of therapy with medications. The style of therapy that works is a big category called cognitive behavioral therapy. For anxiety, what we try to do is we identify the distorted thoughts that cause one to be more anxious, and then we subject those to logical scrutiny so as to change them. The behavioral part of cognitive behavioral therapy is we teach techniques to relax, breathing techniques that can stop a panic attack in their tracks. For OCD, we do something called graded exposure and response prevention, where we intentionally and with the cooperation of the patient expose them to situations that will make them want to do the compulsion and then have them delay it. In a little town in Maine where I practiced, the final exam for my germphobic OCD kids was that they would come at lunch and we would walk the 6 blocks from my office down to the hot dog stand. And we'd touch the parking meters and everything else, and then we'd eat without washing our hands. And if we could do that, we knew we passed the final exam. There was a weird guy at Irvine 20 years ago who took it one step further. His final sessions were always last patient of the day on Friday and were spent in the dumpster for the office building. A little much for me. I'm quite a little germphobic myself. Oh, let me come back to the medications. Medications are very helpful for anxiety. Most commonly we use things called selective serotonin reuptake inhibitors. They were FDA approved initially for depression. The good news is they are even better for anxiety than for depression. Huge multi-center study was done a few years ago called the RUP, Regional Units on Pediatric Psychopharmacology Anxiety Study. Well, about 80% of anxious kids respond quite favorably to serotonin reuptake inhibitors. But what surprised everyone was the amount that it improved the anxiety. It's a statistical measure called effect size. Was the largest effect size ever demonstrated for a psychiatric medication in children. It was even bigger than what stimulants do for severely hyperactive kids. So we're not talking solo response, we're talking an oh my God response with these meds. Major depressive disorder, or what used to be called clinical depression, requires at least 2 weeks of a very sad or irritable mood associated with at least 5 of the symptoms I'm going to list. The first one is a sleep disturbance. It can be an increased need for sleep. It can be insomnia when you try to fall asleep. It can be waking up early in the morning, unable to fall back to sleep, or frequent awakening at night. Loss of interest in one's usual activities, so things that you've always been passionate about. When you get depressed, you know, you don't feel like doing it. Guilty or negative thoughts, or a sense that one doesn't really have a future. You know, I'm a terrible person, I brought all this on myself, the world might be better off without me. You know, this sort of thing. I'm the cause of all this trouble for my family and friends. And then often these folks really, when they're in the depression, they don't have a sense of their own future. They just sort of can't see the next step, and they lose perspective, which of course is a risk factor for suicide. Diminished energy is another one of these signs. Even if you can get yourself out of bed and go do something that should be interesting, you don't have the same get up and go. Impaired concentration, which is, again in kids, primarily evidenced in school. Their grades start to drop, their homework starts to have more silly errors, that sort of thing. A change in appetite, it can be increased or decreased. A physically slowed appearance that is, any of us, we all sometimes will see someone and say, wow, they look depressed, you know, because they're kind of slow moving and they look like they're carrying a heavy burden. That's one of these 5 signs. And a loss of libido or a reduced libido. Of course, where adolescents are concerned, I think they have to be almost dead before they lose their libido. But, all right. As with the anxiety disorders, depression is incredibly treatable. The vast majority of people are readily brought to a state where they are no longer depressed at all. They're sleeping normally, they're eating normally, they have normal concentration, energy, and interest in doing things. Some cases are tougher than others. Those are the cases that usually come to see me. The treatment of it relies on both therapy and antidepressant medication. Medical issues can also be part of the problem. Iron deficiency anemia. You know, 20% of reproductive age women, including teen girls, are iron deficient, and that can present with depression. Used to never see it in boys, but now with people's eating habits and that they just don't really eat real food, I'm having a run on iron deficient anemic boys as well, so I always check for that. Low vitamin D can be a factor in inducing a depression, and you can't believe how many young people are vitamin D deficient right now. You know, they don't drink vitamin D fortified milk, and instead of being out in the sun like I was growing up, they're in front of the screen. And we're even starting to see rickets, the old bone disease, again in the young child population. It's unheard of. Low thyroid hormone can also present this way. So we check for anemia, we check iron, we check vitamin D levels, we measure the various thyroid numbers as a part of the workup. And of course, I don't have it down here, but of course, substance abuse can precipitate a depression. Let me see if I address. No, I'm going to come back. The type of therapy used for major depression most commonly relies on, again, cognitive behavioral therapy. The cognitive piece is that we identify distorted thoughts that we have about ourselves or our environment, You know, for example, a real common one for teens who are depressed is nobody likes me or I'm really ugly. We'll take nobody likes me. So we write that down at the top of a sheet of paper. We do a line down the middle. On the one side of the paper, we write all the evidence that no one likes you. And we sit there and encourage the teen to write it all down, every single piece of evidence that they can find. And on the other side of the paper, we write down the evidence that someone likes them. And invariably, the evidence that someone likes them is substantially higher than the evidence that no one likes them. And at the end of it, we find a way to restate the thought in a more balanced way. Most people like me, but some people don't. Again, it's very pencil and paper. When you do this with teens, they have to like you and have to be engaged, or it feels like homework. The behavioral part of cognitive behavioral therapy of depression involves doing things that are known to improve mood. For example, getting regular exercise helps. Getting out in the sunshine helps. Eating something approximating an appropriate diet, also helps. Leaving the house and doing the things that you don't feel like doing helps. And so we work with kids and families to do all of those behavioral things, do the cognitive therapy, use the medications, and make sure we're not dealing with something more medical. All right, bipolar disorder, very near and dear to my heart, is characterized by either manias or very mild manias called hypomanias. The only difference is how much life impairment you have, and there's a gray area to judgment call. But you don't ever need to be depressed to have bipolar disorder. Some people only have manias. But if you have only hypomanias, never a real mania, you have to also have had major depressive episodes to get this diagnosis. The other mood state of bipolar disorder, which is hardly ever talked about, is the mixed state. And the mixed state is typically a combination of the racing thoughts and increased energy of a mania, paired with the incredibly uncomfortable, agitated feeling of a depression. It's like a depression on steroids. And that is the state that I believe the vast majority of mood disorder suicides occur in. It's also a state that's readily precipitated by antidepressants, especially selective serotonin reuptake inhibitors. So when you hear the story about the kid who got depressed, went to the doctor, got put on whatever your serotonin antidepressant was, looked good in a week, and then was dead a week later. This is usually the reason, which is why people have to be thorough before they prescribe medications. You don't want to miss a bipolar disorder and do the wrong thing. What are the symptoms of mania? Well, reduced need for sleep. Sometimes in severe cases it can be no sleep for days and days. More commonly it's 6 hours, 5 hours, 3 hours a night. This is associated with a much higher than normal energy level, a markedly increased sex drive. Over the past month I've seen a couple of high school boys who are diagnosed with bipolar disorder. And we're talking 6 different sexual partners on a Saturday night, kind of sex drive. They can become very impulsive or engage in dangerous behaviors, not infrequently getting them in trouble with the law. So you got this good kid who about once a year goes off and does all this wild, impulsive, hypersexual stuff. Often that's evidence of a mania. Increase in spending is also pretty characteristic of a mania. Racing thoughts. And that the trick is how you take the history. If you just say to a kid, do your thoughts go fast? They'll probably say no. What you lead in with is, are there ever times where you don't need to sleep very much, but have lots of energy anyway? And if they say yes, you say, I want you to think of one of those periods and describe it to me. And you listen, so you're not contaminating what they're telling you. Then you ask the follow-up questions. Okay, during that time, exactly how much sleep did you get and how many days did it last? Were your thoughts slower than usual, normal speed, or faster than usual? Were you more interested in sexual matters, less interested, or about the same as usual? So again, when you take the history, you don't feed them the answer. And that's really important, again, to not contaminate the interview. One gets an inflated sense of how great one is or one's special abilities. The cutest description of a mania I ever heard was from a manic patient on my unit about 18 years ago, who told me that they felt so good they were Jesus, Willie Nelson, and Elvis all rolled into one. It wouldn't be those three characters anymore. Jesus might or might not make it, but Muhammad Ali would, though. Do you know who has the most recognized face in the world? It's not Jesus. It's Muhammad Ali. I saw a study on that, if you can believe that. Anyway, increase in goal-directed activities. One can become more productive early on, but then, of course, as one gets more frenzied and more scattered, then that pretty quickly breaks down. This can be difficult because, I've treated a fair number of kind of creative business execs who really love their manias, and it's very hard to get them to give those up. You know, they say, I don't want to get rid of my manias, just keep my depressions away. Rapid speech is really hard to interrupt. You just can't get a word in edgewise, as we said when I was growing up. Markedly increased religious thinking is often present. I'm on a mission from God. God is talking to me. I only agreed to be admitted to this facility because I've been told I have a mission to save the people on the unit. This sort of thing. Mixed states. I alluded to them already, but I'm going to really hammer away at this because, the doctors aren't recognizing these, much less the lay public. Mixed states are a third, potentially dangerous mood state of bipolar disorder. There are actually 4 states in bipolar disorder. The fourth is a normal mood. So, had I gotten the name, it would have been quadripolar disorder. But in these mixed states, one has racing thoughts, often high energy, sometimes high libido, and extreme irritability. And for the person who's in this state, particularly if they're young, they do not realize that they are irritable, but they are enraged with you for pissing them off and being so irritating. So they don't see the problems within themselves. They see it as very justifiable when they're in this state. Often there is a strong desire to suicide in the mixed state, and this state can be induced by antidepressants, particularly SSRIs, which is why no one should go on an antidepressant without a structured interview to look for evidence of a hypomania, and without asking about family history as well. Possible consequences of major depression or mania. Well, suicide, highest in the mixed state, but also high in a depressed state. Poor school performance, if you've lost interest and you can't concentrate and all you want to do is sleep, it's kind of hard to do well in algebra. Impulsive behavior that can often lead to trouble with the law in adults. Some of the folks, they'll make bad investments, or they'll take off to Vegas and gamble, whereas they're not usually a gambler, and lose all their money. And unsafe sexual behaviors are quite common during a mania, and of course that can lead to a host of issues ranging from pregnancy to STDs. Treatment of bipolar disorder. Again, this is a highly treatable disorder. I mean, there are cases that are harder to treat than others, but I think I can count on 3 fingers the number of people I was ever not able to get reasonably stable out of a few thousand, who did not go off and do drugs of abuse and took their meds. You know, if they're doing drugs, all bets are off. The details of treatment are going to be covered in a bipolar-specific lecture. In general, we use medications called mood stabilizers as well as therapy. If you want to look up the therapy that's the most well-established as working for bipolar disorder, it's a combination of techniques, but it's been packaged under the label of FFT, Family Focused Therapy, and you can look that up and read about it if you have an interest in it. It's essentially a set of cognitive and behavioral techniques and environmental intervention, kind of all packed together. The mood stabilizers, I'll just mention a few: lithium, Depakote, trilethol, Tegretol, Lamictal. And then there are medications that were originally approved to be antipsychotic that have mood stabilizing properties, depending upon how you define a mood stabilizer. And you'll have to come to a bipolar lecture to find out what I mean by that. We try to avoid antidepressants in bipolar folks. There are drugs we can reach for that are not antidepressants, that are unlikely to precipitate mixed states, but treat depression in this population. Eating disorders. Anorexia, nervosa, and bulimia. Anorexia is characterized by the strong belief that one is fat. I mean, disgustingly fat, despite that any observer would say otherwise. It can reach the point where people are dying of starvation and they think that they're fat. This was driven home to me when I was a resident at Stanford on the Roth unit, which was our psychosomatics unit. And the guy who ran the unit had the habit of putting butcher paper up on the wall, and then we would ask the anorexic to do a life-size sketch of themselves. And these, 5'9", 79-pound unstable anorexics would draw these grotesque, huge Pickwickian figures. And that's what they see. Their thinking is really that distorted. And I had such trouble wrapping my head around that and understanding that when I was first studying this. These folks will engage in extreme efforts to control their weight, strong calorie restriction, excessive exercise, sometimes purging. We call that the purging type, and that can involve making yourself vomit by mechanical means or chemical means. It can even involve inducing diarrhea in order to move calories through quickly. The vomiting is super dangerous because they can develop heart arrhythmias that are lethal if they do enough of that. They have this extreme fear of gaining weight, obviously. Bulimia is characterized by episodes of binging, which involves eating really kind of astonishing amounts of food in a relatively short time period, often to the point of feeling sick. A gallon of ice cream, in a half an hour, 8 bags of chips. I mean, just, we're really talking large amounts of food. They too are obsessed about the body and their weight, and they feel terribly guilty and ashamed, often depressed after a binge. They typically will induce vomiting or take laxatives to try to counter the effects of the binge. Well, possible consequences of eating disorders. This category of disorders is the one where, when I teach the residents, I say these are the people that will die on you if you don't pay attention. Starvation, and they hide it well. They'll be in these baggy clothes, and they'll make themselves up, and to the untrained eye, they won't look that thin. Electrolyte imbalances, particularly if they're inducing vomiting, can lead to heart problems, basically a heart attack. Liver failure can also occur from starvation. And suicide is a not uncommon outcome in anorexia. Most of them, if they're low weight, get quite depressed. And the interesting thing is, unless you get weight on them, the traditional treatments of depression are pretty ineffective. In fact, the school of thought I was brought up in is that even therapy doesn't do anything until they're no longer started. Their thinking breaks down. They really can't process it. Weak bones that become more of a problem, so an early onset osteoporosis as folks get older. Weak muscles, hair falling out is not uncommon. Teeth being damaged by stomach acid from vomiting. The dentists often see this on molars. Other nutritional deficiencies. And whenever I meet a thin-looking young person, particularly a young woman, I always shake hands with them. And when I shake hands with them, I run my thumb right over this part of their hand. Because when they induce vomiting, the head goes forward and they nick it there. And there's often a callus that you can find in your perjures. It has a name. It's somebody or other's sign, but I'll be darned if I can remember whose sign it is. Eating disorders also are highly treatable. However, it's slow going and it's long-term treatment. Medications alone aren't worth much for an eating disorder. They can help aspects of the disorder, but really we stabilize them medically, and then we involve them in pretty extensive individual, group, and family therapy, and over time chip away at their distorted body image and form an alliance with them, with the side of them that wants to be healthy. I would say the average teen anorexic, at least 24 months to really get them functioning better. And bulimia, that one's all over the map. I mean, so many kids just try it for a week or two and stop, and then you've got a large number of people who are bulimics for life. Teen suicide, sadly, after decades of declining teen suicide rates, they're going back up again. And this happens to coincide with the FDA's decision to place a black box suicide warning on antidepressant use in children and teens. I'm not going to beat the issue to death, but suffice it to say that the retrospective study done in England on kids taking Paxil that basically said more kids on Paxil think of suicide than kids not on Paxil. The study didn't control for level of depression or the fact that we're more likely to medicate, sicker kids. That led to this mass hysteria at the FDA in throwing this warning on everything, even stimulants and anticonvulsants. A significant number of the people on the committee that did it are on record saying this was a horrible mistake. But people then became afraid to prescribe or have their children on it, and we're heading back to 1970s suicide levels. We had a 30% decline in death by suicide in teens with the advent of a more common use of pharmacology. I guess I could cover all that. See, I don't even have to look at the slide. It's something I'm passionate about. What are the stats? Well, 4 out of 100,000 teen females and 16 out of 100,000 teen males die by suicide annually. So even though the girls attempt far more and talk about it far more, 4 times more boys die. This is because of the method that they choose. Boys tend to choose a self-inflicted gunshot wound, hanging, jumping, these violent means. Girls are more likely to do overdoses. And at least in this country, where we have pretty good control over toxic chemicals and drugs, and we have good poison control centers, ready availability of ERs, the mortality rate is low. Interestingly, if you go to third world countries, the death rate's about the same because they have access to meaner chemicals and they don't have access to our modern ER miracles. The characteristics of people who die by suicide, that's what a completer is when I say completer. They're often substance abusers. They're often aggressive. They're often depressed or bipolar. If you have a mother, father, or excuse me, if we look at all the teens who died by suicide, this was in the New York suicide study, they looked at every suicide death over a multi-year period. Almost 50% of those kids that died had a mother, father, sister, or brother who died by suicide. What does that tell us? Well, if we've got a kid in our family or our school or our neighborhood who has a brother or sister or a parent suicide, that kid has to be watched and supported very, very carefully. 10% of these suicides you just can't quite figure out. You know, you do the psychological autopsy, you look, you can't figure it out. I did a series of these when I was on the East Coast, because in the state where I was practicing, nobody was willing to do them. And what I found, at least in Maine, which has an incredibly high bipolar incidence because of the genetics of Maine, was that almost every case I looked at was a mixed state, frequently precipitated by antidepressants. Family history is a major risk factor for suicide, as I just said. And experiencing the suicide of a family member, everybody says, oh, I will never do that because I saw what it put everyone through. Well, that's not what the statistics say. And families often are so traumatized by a prior suicide that they're just unable to see the warning signs in the other family members. So I'm going to teach you an acronym for how to recognize what I've called teens at risk. Some of them are at risk of suicide, but they're at risk of academic failure, social problems, all kinds of things. So this is a screening tool, and it's a way to think about kids who you come in contact with. But it's not specific. I mean, the majority of kids that get identified with this are never going to suicide. So one of the things we need to do is think about the teen using the HEADS approach, which I'm going to describe. The second thing is, when we identify such kids, we need to get them help. I mean, you know, whether we start with a school nurse, a school counselor, the hotline, looking at the resources on the county mental health website, the pediatrician, whatever it is, we need to get them help. I always put in a plug for the Yellow Ribbon program. It's a program that's run by volunteers, and it essentially trains peers in high schools and colleges to recognize those around them who need help. And it's really a very effective program. And these folks are trained, these kids are not trained to go do therapy with them. They're trained to bring it to the attention of someone who can help. And we ought to have one at every high school in town. At this point, I think we have one at every college in town. We might not have one at Point Loma, but I think all of those have it. Great program, and if any of you are wealthy philanthropists, after you give the Bipolar Foundation money, you can give a few dollars to the Yellow Ribbon program. So the HEADS exam, it's an acronym. Each letter stands for a domain of functioning that we want to think about, or at least in my case, when I'm interviewing kids, I actually ask about. I want to know about their home, and we'll talk about what we want to know, their school function, their education, what activities they're involved in, what their experience with drugs and alcohol. Alcohol's a drug, so I call it all drugs, is. I want to know a little bit about their sexuality and what suicide thoughts they've had. So at home, are they functioning at home? I mean, are they, basically able to interact with their parents and siblings? Are they, in an age-appropriate way, able to more or less follow the rules? Is their defiance excessive? Sometimes hard to tell when you're a parent. Is the teen even living at home, or are they doing couch surfing between various houses because they're not able to function at home? Is there a parent or sibling with a mental illness or substance abuse problem? That, frequently there is, and that can really affect a kid's functioning in all domains. Education. What are their grades, but more importantly, have they changed lately? A precipitous drop in academic performance is a warning sign that something is going on. Is their social functioning age appropriate and healthy? Is it a a 15-year-old girl who only hangs out with 25-year-old guys? That's a problem. Is it, the 14-year-old boy whose best friend is 11? That's a little concerning too. And so we want to look at their social functioning. Is the teen able to follow the school rules, behavioral norms reasonably well? In other words, are they on a first-name basis with the principal? Are they attending classes regularly and arriving on time? If they're not, where are they? Are they smoking pot in the parking lot? What are they up to? Activities. What do these kids like to do? And you ask them, people always want to talk about what they like to do. And when you hear those, are those activities that you would expect a person of this age to engage in. Do they have a sudden interest in new, particularly dangerous activities? The kids growing up into a hypomania or a mania will sometimes take on these incredibly adventurous, dangerous notions about what activities they're interested in. Are they engaging in activities with a decent peer group, or are they really affiliating primarily with other troubled teens? And this is the one these kids get missed. Are excessive worries keeping them from activities or from making friends? The excessively inhibited teen also can have issues. It's not just those actor-outers, and the quiet ones get missed. And has the peer group for this teen changed? And if it's changed, it's not necessarily bad. Sometimes it's good, sometimes it's bad, but you want to know how it changed. All right. The D is for drugs. What is the teen's experience with alcohol and drugs? I have never, ever asked a teen, do you do drugs, do you drink? I don't ask that question. I say, how much do you drink, and what drugs have you tried? Because the message there is, it's okay to tell me. And they'll say, no, I don't do any. Well, great. But that's not how I like to ask it. I would say the overwhelming majority of high school students who I see have experience with alcohol, not infrequently substantial binge drinking. Binge drinking that is unlike anything that we old people ever even dreamed of in high school. And what drugs, and what do they consider to be a drug? You'll have the kids that are daily cannabis smokers who say, I don't do drugs because cannabis is natural. And I always say, so is dog poop, but don't smoke it. How much, how often? If you're a parent and your kids are wanting to do sleepovers, you need to know where they're sleeping and know enough about the other parents to know what's up. We have people all over San Diego who thinks it's a great idea to provide alcohol or drugs to kids at parties that they host, because after all, they're going to do it anyway, and my house is a safe place. The oldest trick in the book is, I'm sleeping over at my friend Joe's house, and Joe says, yeah, he is, and then you're really off, kind of up to no good. Use of anabolic steroids, this comes and goes, but it's not uncommon at this time. Over-the-counter meds with ephedra's been banned, but Sudafed's, the old congestant that's now kept locked up. Energy drinks, caffeine, guarana extract are often in these energy pills that you can get at the 7-Eleven, Mach-1 extract. The reason I ask about this is kids can really get themselves incredibly charged up with this, and it can precipitate anxiety symptoms and mood symptoms. In a vulnerable person, it can precipitate a mania. And are we finding empty, paint canisters, aerosols, whiteout, air freshener, way too many whipped cream, nitrous oxide canisters, butane, plastic bags, cough with solvent smell, this sort of thing? Inhalants come and go in popularity. It seems to me like maybe this year they're coming on again, more popular. And then finally, the narcotics, any kid who wants them can, within an hour, if they're at all sophisticated, acquire Vicodin or Tylenol number 3, at their school. It's that easy. Soma is one I like to tell folks about. It's a muscle relaxant, also very easy to acquire on the street. And the kids like Soma. It's been popular for a long time at Torrey Pines, but Torrey Pines isn't alone. And what they like about it is at the schools where they breathalyze at the events, the kids use Soma to get an alcohol-like effect, and they blow a 0 on the breathalyzer. Furthermore, routine urine drug screens don't test for this. So, you know, if you've got a kid that looks intoxicated, they're blowing a 0 and the urine drug screen is negative, you actually have to do a specific blood test for Soma, or you're never going to find it. And believe me, the high school kids know this. Sexuality. Are they comfortable with their anatomic gender? They're being male or female. Are they comfortable with who they are attracted to? You know, whatever the attraction is, are they okay with it? Are they promiscuous? That can be a real sign of trouble. But also, are they overly inhibited? I mean, are they graduating high school and have never kissed somebody or, you know, held hands? I mean, that's a concern. Are they engaging in dangerous sexual behaviors? And has the increase in sexual matters suddenly increased as in mania or decreased as in depression? And again, I never ask a teenager if they've had sex. I say, how many sexual partners have you had? And if they say none, I say, what about oral sex? Because ever since Bill Clinton, all kinds of sex are not sex anymore. Because he did not have sex with that woman. Sorry, he raised my taxes. I have to do that. Suicide. If you ask 15-year-olds, have you thought seriously about suicide in the past 3 months? About 30% of them will say yes. So suicidal thoughts are extremely common. Much more common than suicide attempts and much more common than death by suicide. So has the teen thought of suicide or that the world would be better off without him or her? Have they considered ways of doing it? Have they selected the way that seems best to them? Have they acquired the materials or sort of rehearsed it? Like, you know, tied the noose, thought about the place to jump, you know, gone there, looked over the side, that sort of thing. Have they made previous suicide attempts? And what did they consider to be an attempt? And you have to understand that many kids are unsophisticated. I had one in my office the other day who is suicidal and told me he made an attempt the month before. And I asked him what he did, and he took 8 aspirins. And in his mind, he expected that to kill him. Again, these kids did not know how to look up LD50s in the BDR. So, and again, usually I ask this in order. I say, well, you know, have you ever wished you weren't born, or you thought the world would be better off if you weren't around? You ever thought about finding a way to get yourself killed or to suicide? And again, so I work my way up it, because if you open with the S word, they're never going to tell you. At least most of them won't. And again, since the HEADS acronym is a screening exam, we need a standard for referring to a professional. Certainly, if there's significant life impairment, what I call major difficulty in any one area, they absolutely need to be evaluated. I think moderate in any 2 areas, but really the kid who's having mild difficulties in multiple areas probably should be assessed as well, because the consequences of missing a mental illness can be major. And if we talk about how to prevent teen suicide. Let me see if I put these slides in or not. Yeah. My problem is I'm doing talks all over town of different lengths to different audiences, so sometimes I can't remember what I put into this group or the other. Suicide, years ago, San Diego did a famous experiment where we held an anti-suicide telethon. And you know, lots of people called in who were suicidal. They got hooked up with services, etc. This was in like 78, 79 is when it was done. I remember I was here. And what happened was exactly the opposite of what anyone thought. The suicide rate in San Diego County spiked, massive number of suicides. And there was debate at the time. Was that because these were people that were going to do it anyway, and this just triggered it? Or were these people who suicided who, but for the telethon, might still be alive? And if it was people who just kind of impulsively did it, and then would have expected a drop in the suicide rate in the ensuing year or two after the telethon, because the ones that were going to kill themselves did it, and you would expect it to drop. We didn't get the drop. It's called the San Diego Suicide Study. It's one of the most kind of famous studies. So what doesn't work is going to groups of kids and talking a whole ton about suicide. That is actually a bad thing to do. There are two things that really do work. The first, and if somebody gave me $1 million and said, I want you to definitely reduce the death rate by suicide among teenagers in San Diego County, I would go buy $1 million worth of trigger locks and gun safes. This has been done in numerous communities, and it massively cuts the death rate due to suicide, getting those firearms locked up. And a lot of folks are into their firearms, and what I do when I'm trying to talk to those folks, we come across as anti-gun, they never listen to you. So what I do is I say, well, have you taken any of the NRA safety courses? And they might say yes, and I'll say, well, okay, they talk to you about how to secure the guns. What do? They're in a locked cabinet. What's the cabinet made out of? Well, it's pine with a glass front. And where's the ammunition? Well, it's in the pine box too. So you talk to folks about trigger locks, ammunition separately locked, guns locked, and not in anything that a person can take apart if they're going to have guns. The other thing that works is identifying people with mental illnesses and treating them. When I first got interested in bipolar disorder, the death rate among people who were bipolar due to suicide was 20%, 20%. The current evidence is that it's a fraction of that. What's the difference? We're treating these folks. We're treating them more effectively. Most of us are not giving them antidepressants, this sort of thing. And so identifying people with illnesses that can lead to suicide and getting them help makes a real difference. Suicide hotlines, I keep them running, but the evidence is that the aggressive young males who are at the highest risk of suicide won't ever call a hotline. So, thinking that just because we have a suicide hotline, we're doing our job in the community, absolutely not. The summary, and as promised, we're going to have a ton of time for questions and answers. Anxiety disorders, mood disorders, eating disorders, and suicide are common diseases. Most suicides can be prevented by identifying folks with mental illness or substance abuse problems and helping them to get treatment. We go for water, and then I'll start answering questions, which they'll hopefully be fun. I'm going to start here and work my way over.
I've been having great difficulty with my son since October, and we had him on antidepressants.
How old is he?
19.
Okay.
Everything you said, he is. And talked about suicide quite a bit, and I left him alone tonight, which I don't know if was a good idea. I went to the doctor with him and said, what can we do about the antidepressants? He upped both of them.
I'm sorry, he changed 2 drugs simultaneously?
He put him on, he's had many drugs.
Okay.
There's so many. More recently, it's been Wellbutrin at 300 and milligrams and Lexapro at 20, and he was upping it to 40. And trying to reduce the Wellbutrin to 100 because he has all this aggression, everything that he said, the racing thoughts, can't stop moving. Talks about the same thing over and over. It's very fast. We were up to 4:30 last night.
So he's not sleeping either?
Oh, he can't sleep. He doesn't eat.
Well, your son is most